Folks, super excited to introduce our guest today, Dr. Julie Chen. Dr. Chen is the Chief Medical Officer at Radence, and for those of you who can see the visual, you can see that behind her. She previously served as the Chief Medical Officer at companies like Human Longevity and Vitagene. She is a researcher as well as a clinician. She's researched at the FDA, the NIH, the National Cancer Institute, USC, and the Mount Sinai Hospital. And her focus has been in something called precision medicine, which we're going to get into. She's developed numerous corporate wellness programs focusing on a whole systems approach to healthcare. And she just has a really remarkable background, which I could go on and on about, but I just really want to start picking your brain, Dr. Chen. Thank you for spending some time with us today.
I'm happy to be here. Thank you for having me.
So, Julie, if you don't mind my calling you Julie, a lot of physicians I've been interviewing and speaking with over the past couple of years started out in traditional medicine, internal medicine, family medicine, and over the course of decades shifted into lifestyle medicine, integrative medicine. I get the sense that you started out pretty early on in your career focused on integrative medicine. Now you are an internal medicine physician, but you got into this other field. So I'm very curious, when did you get into this? Also, the fact that you've done research in this is really fascinating so early on and curious. So if you can give us a little bit of background, I'm really curious.
Sure. Yeah, you can kind of say that I probably grew up in this philosophy in the sense that growing up in my family, when I would have sprained ankles as a child, my mother would use ginger, instead of, let's say, like topical cream. So, and I had all of my uncles were actually doctors. And I think growing up in this sector of understanding the intersection between what some people may call alternative or Eastern medicine and Western medicine was very interesting for me in the sense of that. I think a lot of times people pick a sector, but to me, medicine should really be looking at the whole person. And what really kind of transpired over time was that as I went through training and I started to come out into actual practice, very quickly within the first couple of months, I really figured that by seeing medicine in action, not just in training, but as attending and seeing it in practice, I recognized that there's a watershed period of time before people truly became sick where they may start to not feel well. They may start to have symptoms. If someone's a great reader of their own body, which I'm very confident that a lot of people actually know their bodies very well. And I think it's very important for medicine and people in medicine to recognize that and take what people are saying into true validity into what they're saying that they're feeling. And it takes time before the labs and the testing may start to show the actual abnormality, especially when we're looking at the testing modalities that are typically utilized in conventional medicine. So very early on when I started in my career, I started to realize that a lot of people were coming in not feeling well or starting to feel towards like illness, and the testing that was being done in conventional medicine wasn't picking it up. And so I wanted to really get to this concept of root cause, illness, and how we can really pull people back from the precipice if they were starting to go in a direction. That's actually the best time to actually help someone, because by the time you wait until someone is really showing a lot of symptoms, the physiological shift or the disease state has more progressed farther along, and it's harder to actually recover cellular functioning. And so when you can find someone actually earlier on, the importance is that in that period, you actually can hopefully bring someone back into more of a fully functional, healthy status. And it's easier to do so because a lot of the cellular physiology is still viable.
So give me an example of that, because it's interesting. I felt early on in my career something very similar to you, that people would come in and there wasn't, let's just take a very concrete example: high blood pressure. So you would throw medications at them and to try to bring the blood pressure under control. High cholesterol, sugars that were elevated. So these were chronic diseases, obesity, et cetera, that over time could lead to more serious things, like obviously with high blood pressure and diabetes. In high cholesterol, you're talking about heart disease, strokes, heart attacks, heart failure, kidney disease. So how did, and I was always a bit frustrated with that myself, and didn't know what to do. How, when you say, finding it early with other tests, and so give me an example, some sort of concrete example, especially like from early on in your career where you said there's got to be a better way than what I'm doing.
Yeah, so if you think about the concepts to your point about cholesterol, even sugars, there's multiple ways of seeing those levels, right? So it's a difference between saying I'm only going to look at hemoglobin A1C, which is your average sugar over 3 months, versus looking at the nuances of, let's say, do they have fatty liver? Are their fasting sugars starting to be in the concept of like glucose intolerance? If you fasted for 12 hours, why is it 99? But the hemoglobin A1C over the average of 3 months might look okay if they're having certain weeks or months where they're okay, but then other months are not. Because again, it's never, to your point, a all or nothing. It's not like they're just great all the time or they're horrible all the time. There's always these nuances in early disease where your body's trying to survive and optimize. And so if you're not looking at the nuances or the shades of the physiological differences from a day to day, you're really going to miss those early changes. And so similar concept with cholesterol. If you look at just LDL or just HDL and not looking at LDL particle numbers, not looking at apolipoprotein B, what if someone has lipoprotein A? Like, we are now starting to really look at it more, even from most doctors' offices, they're starting to look at it more. But this is something that's been around obviously for decades. I mean, you could have looked
Right.
at this like decades ago,
Right.
but they're not, right?
Right.
And calcium scoring, even when I first started my practice, and I even want to go into how many years ago, but we're talking about 20 years ago,
Right.
where calcium scoring has been around for a long time, but insurances and doctors weren't really ordering them. And I remember in my early career, I would be pushing for these, and the doctors that I would work with, some of them who are more forward thinking would say, yeah, let's definitely do that. Insurance may not cover it, but members may say, you know what, I'm willing to pay for that because once you go over the benefit. But as far as like insurance based and conventional, it took a while to adapt. And I think that's one thing that Radence really focuses on, is this concept that we know that a lot of technology, from the emergence to the true day to day utilization, it sometimes can take 10, 15, 20 years to get there, but not,
Right.
but why though, right? Like, why wait for that when you know that that technology for those people in those 10, 15, 20 years could actually benefit? We should be trying to compress that timeline of clinical usability so people can benefit from that. So for me, a lot of these like calcium scorings, particle numbers, those things need to be looked at, because looking at one dimension of a disease state, especially early on, where someone isn't so sick that it's prevalent everywhere, you're going to miss that window or the nuance of change in the beginning.
Yeah.
And that nuanced change period is actually when it's the easiest to pull someone back into normality.
So yeah, so give me an example, and I'm thinking, I'm trying to actually bring this down to a very practical level as I'm listening to you speak. And so here's what I'm thinking, and tell me, maybe you have a much better example. I'm thinking about like prediabetes. So we've known about prediabetes for quite some time now. And I remember back in 2011, 2012, doing pre-screenings or screenings in the YMCA's and around the pre-diabetes. What's fascinating is not that long ago, most of the doctors didn't even know what prediabetes was, and so that was, this was like a new concept, even though it wasn't that new. But that was a way to say, okay, listen, you don't have diabetes, but you have this thing called prediabetes, and we know that a significant percentage of people with prediabetes are going to go on to diabetes. But to your point, there's something more going on here. This isn't just a number. It isn't just your sugar, your glucose is elevated. There's a whole metabolic syndrome at play here, and identifying that metabolic syndrome. And what I'm hearing you say is it's not just a number. It's not just the hemoglobin A1C, but there are probably numerous other tests and evaluations that can give a much bigger picture of the metabolic disease and help us understand where you are, and then focus on preventing that. So maybe fill in that picture if you can a little bit.
For that person who has prediabetes, we're looking at potentially other metabolic factors that are starting to come into play, right? Whether the person is starting to have where the carotid enema media or the thickness or plaques are starting to build, whether they're microvascular in the brain is starting to have what we call like white matter lesions or scarring. Because again, dementia isn't usually just Alzheimer's. It's most common as mixed dementia, vascular impact, lipids, inflammation, etc. And so when you take a look at that one person with the one marker that you think is the only thing abnormal, that person isn't just abnormal in that one thing. It's all the downstream implications of where that person is. Now, if that person is pre-diabetic, and let's say that fasting sugar normalizes or that hemoglobin A1C normalizes, my question would be, what about the microvasculature? Is that fine now? What about the cardiovascular inflammatory issues, the carotid intima, wall thickness? Is that still starting to thicken for them? Because people with that even is the beginnings of starting to have cardiovascular disease. Are we now looking at someone who is starting to have actual, inflammatory disease and other factors? Do they have the genetics for autoimmunity? Like what other factors are getting triggered, And so with Radence, we really right now are looking at what we call like the four horsemen of like cardiovascular, neurodegeneration, metabolic, and cancers. But there are so many other pillars. Like, for example, we're looking to add autoimmune and GI factors because everything is tied together, right? Our human bodies are not segmental. And I think that's one thing that also I think in this subspecialty of genomic precision medicine that I'm very passionate, and we at Radence are very passionate about creating a true specialty in this sector, is that we really believe the future of medicine has to be in early disease detection so we can get ahead of the disease state and not behind it. And by doing so, we save so much money in healthcare system because most of the money spent is in the latter 10 years between the end of health span and the end of lifespan. And to your point, like all of these diseases, because again, our bodies are interconnected, they start to trigger down into a snowball effect of now that it's the pre-diabetes to diabetes. Now it's cardiovascular. Oh, wait, all of a sudden this person also has neurodegeneration. Oh, we didn't realize they had ApoE4 risk factors also. And so of course, now we're looking at Alzheimer's. So I think the thing is, a lot of people actually come to us with this concept of, well, I don't want to know. But what I always tell people is that you will know. It's just, if you know early enough, you can do something about it versus if it's coming, but you don't know about it till later, there's not as much that you can do about it. So it's really this empowerment concept of helping people tie it all together. And there's, to your point, so many examples, right? Whether it's the early disease states, the numbers are looking, if you only look in one dimension of the bigger disease state, but then you go and look and you look at the whole person, now you realize they actually have elevated visceral fat, which is the fat around the organs, and they have, increased cardiovascular cancer risk, metabolic risk, all of it.
Julie, you're saying, I mean, there's so much richness in what you're saying. I almost, it's kind of like reading a book and you pause and you got to think about it for a second. So a couple of things you said. First of all, I really think this is really so illuminating for me to, one thing I hear, I think a reframe that's really important here is that we have tended to silo diseases and not make connections. And I think what the science is showing us is that there's a lot more connectivity in between cardiovascular disease and metabolic health and neurodegenerative and autoimmune and the connections to genomics. And so the idea of actually just looking at one or two tests and saying, here, this is what I'm going to follow is really missing a bigger picture. I think that's just such a critical, important point as people often look at what you're doing and what others like you are doing and sort of poo-poo it. I think that and I love the fact that it is sort of like we're almost coming back to this understanding, like, it's like one whole body, right? It's like one whole person. We're actually not disease states. We're actually an organism, right? And the second point you made, which I think is really important, is people look at the costs of these things, and we can get into that in a little bit, but I think and I'm curious as to if there's been any evaluation of this. Doing what you're saying, doing the testing does cost money. Tests are expensive, treatments are expensive. Having said that, to your point, the amount of money that is spent in the last 10 or 15 years of life. And so right now, I just saw this stat that Americans live on average to 79 years old, but they only live until 65 years old in good health on average. And so there's a 15-year period of disease and disability That's a long time.
Right.
And in that time, there's a lot of medication and a lot of surgeries and a lot of hospitalizations that happen. And to your point, tremendous amounts of not only suffering, but a lot of money spent. And the suffering is not just the individual, the suffering is the family caregivers. So you're talking about a whole bunch of pain and suffering and financial hardship. And you're saying, hey, listen, this may look like it costs a lot of money, but in the end, net net, we're actually going to save money. So I do think that's a really, really important point. Even things like you mentioned a few minutes ago about fatty liver disease. The fact is now I'm thinking, and you're making me think this, you know, if someone's going to have a metabolic illness like diabetes, why aren't we checking them for fatty liver disease? Because we know that about a quarter, literally at this point, I think it's something like 25% of US adults have fatty liver disease. A certain number of them are going to progress. I mean, I've had friends who've called me up and said, hey, I was just diagnosed with this thing, fatty liver disease. And I'm like, listen, you're not alone. This is actually a fairly common thing right now. It didn't exist 30, 40 years ago. It is now becoming epidemic.
Yes, and to your point, I think this concept, going back a little bit to the point about those last couple of years, 10, 15 years, and what that means for society, there have been studies that did demonstrate that if you find something as stage 1 versus stage 4, the healthcare cost save is massive. They were only looking at the cost numbers being saved on the healthcare, but if you think about the contribution to society even, right, and how it impacts the family, to your point, is so important. And so when you bring up this concept of like, why aren't we looking at fatty liver? I think traditionally in historical kind of conventional medicine, where they're looking at the lifespan save rather than the health span save, there's that in and of itself is a different conversation, right? Like, because the ease of doing a blood draw versus sending everyone for imaging to look for fatty liver, the resource discussion, the cost discussion of that, the time spent in doing it. But then if you flip that and think, but the time spent on saving them being ill, going to the hospital later, it's actually significant. But, I think this, to us, really, this concept of changing how we look at medicine, it has to be a philosophical change, right? It's not looking at just extending life, but it's extending the valuable years of life and the health span of that and how that impacts society, families, your individual person. All of those things should be looked at. And I think ultimately the extra time needed to go get the imaging done on the fatty liver, ultimately, because it's reversible, it's going to save a lot of time and money and energy later on, and a lot less anxiety if you knew about it now, because it's reversible. Versus, a lot of people may not be even aware that cirrhosis in the US, one of the major factors is fatty liver, and it's avoidable. So when you really think about that kind of time commitment, the early time commitment actually gives you a lot more bang for the buck than if you waited till later. And I think this is just a philosophical shift. And so for me, it's been so important as a company that and this is why ultimately I joined Radence. As a whole, the company really values this concept of like a movement, an evidence-based movement, and really shifting medicine towards this kind of concept of early disease detection and changing and helping people sidestep disease. And I think because of this concept that we're really coming from a place of wanting to be scientifically and medically based, and that's why larger academia institutions want to work with us, because our whole goal isn't just for academia and conventional medicine to be okay with us. It's we want them to embrace this concept so that this can be the beginning movement towards the future of medicine being practiced this way. And so to us, everything has to be evidence-based and scientific.
I am interested. If I came into Radence right now, and you mentioned the four pillars of neurodegenerative, cancer, cardiovascular, metabolic. What is the? I know you have sort of a 7, 8, or 9 or 10 sort of areas of testing. So what would that evaluation? Let's say I came to the office as scheduled, and so what would it look like from a patient consumer experience? What are you testing, and then how would you get me the results, and what would that conversation and that sort of thing? What does it look like?
Sure. So I would love to walk you through the journey. And I think that's really important for people to kind of understand. I think that's a great question because when people come in, one of the frequent questions we will get is, what about all the data I've done from before? And so
Mm,
if we're really going to paint the picture of the person as a 360, all of the prior data, however many tests or as little tests as they've done, like we want all of
mhm,
it. And so we get
mhm,
actually all of the data from every doctor, every
mhm,
clinician, every personal test that they did commercialize, all of it. We want all of it because we want to see what actually you had as prior years and what you think is your baseline.
mhm,
From there, then we do a very intensive medical intake. That's actually typically, most medical intakes with doctors are shorter. We do a 2-hour intake just to get everything. We want to know all the symptoms that are maybe starting to occur. But from the
mhm,
testing component of that, we look at someone's, and we actually painted this out in a very logical sense of like starting at the cellular level. We want to know at the cellular
mhm,
level, in the bloodstream, in the cell level, what's the physiology look like based on labs. Then we want to look at like the blueprint of what is your kind of predisposition genetically, and also
mhm,
not just the whole genome sequence, but polygenic risk. What is your body's ability to metabolize medication? So pharmacogenomics, like all of those
mhm,
kind of genomic blueprint components.
mhm,
And then from that, we have an initial idea of what imaging we would do, but a lot of the physiological labs that we do or the genomics comes back, they may not have ever been done. So we actually add that onto the prior picture that you had from outside. And then now we do an even deeper dive on the imaging, whether not just looking at the status of disease that's already here now, but we actually do some imaging that looks at like, is it going in that trend? So for example, I had mentioned the carotid enema media to see like, is your carotid vasculature even starting to thicken? Not just like, is
mhm.
there 70% plaque, but is it starting to thicken? What does that look
Right,
like? And
right.
then from the imaging, then we want to say, okay, we've got the cellular, we've got the genomics blueprint. We now see the end organ impact on the organ end. Now we want to know, what is it like functionally, right? So
Mhm,
we start to look at, what is your formal neurocognitive cognitive status, and what is your wearables for your sleep, your heart rhythm? Like, how is this translating to the day-to-day functioning? And then from that, because we're looking at the blueprint, the cellular level, the organ level, and then now the functionality level, we now know your baseline as of today. And from there, also the importance for people to understand is that if you are looking at someone's trajectory and truly moving the needle in
mhm,
preventing, future disease, you can't look at it from one time point. It's a longitudinal trend, right? So I have to see, here's your brain volume today. What does it look like in
mhm.
5 years? Are you starting to lose brain volume, which could be one of
Interesting.
the earlier signs of, neurodegeneration? What's your proteins in your brain looking like? Is it trending in the wrong direction? We don't want to wait until it's completely off. What is that trend? Like, we're even talking to technology companies that are looking at like imaging for the breast, right? Is it not, do you have a tumor yet, but are the cellular imaging changes trending towards cancer?
Wow.
Those are the things that we want to know about. And some people will say, that causes a lot of anxiety. But the point here
Mm,
is that if it's trending in that direction, though,
right.
don't you want an advocate standing there saying, we're going to get ahead of this before it actually gets there, or watch it so closely that if it were to get there, we catch it as
Right.
soon as it does,
Right.
right?
Right.
So
Right.
again, our bodies will age. I think none of us can argue that we're machines first and foremost. So the point is, do you want a tune up regularly to see that we're
Mm.
catching it before it breaks down? Or do you want to wait until it's broken down and then deal with it? I think that's the big philosophical change we're really trying to help people understand.
And so you've done the evaluation and you're going to be following me up, and I love that. When you discover something, so and this is the real, this is where the rubber hits the road. It's like, so what are you going to do about it, right?
Hmm.
Or what are you going to help me do
Hmm.
about it in terms of, the treatment? And let me be a little provocative here with you in that one of the things I do wonder about is in the end, maybe this isn't provocative, but part of me, maybe it's cynical, but part of me is thinking, well, it's going to come back to very, very similar forms of treatment. I mean, nutrition, changes in diet, physical activity, working on your sleep, stress. I'm curious, how do you have a sort of architecture like you just had for the diagnosis? Do you have an architecture and a template, an approach to treatment? And in that, does it include things like, and we haven't really talked about this, but toxins like plastics and things like that. So kind of curious as to the treatment side now.
Right. So when people are found to have risk factors, which inevitably most of us have, even if you're healthy, there could be muscle imbalance or wanting to optimize
Mhm.
bone, et cetera. So we, again, it's a long-term partnership with people because again, if we find something, there's no benefit in helping to move that needle if we just leave you to it with a data dump of info and then now you have to go figure it out yourself. So we actually walk the journey, the entire journey with our people in the sense that if they have a need to see a subspecialist, we actually not only refer them, but we vet the subspecialist so that by the
Mhm.
time they show up to the visit, the subspecialist already knows what that meeting is about. And we'll actually be in the meetings with the people, with the subspecialist, because a lot of times,
Mhm.
people aren't going in there with medical knowledge, right? So they may not
Right.
know the right questions to ask. So for us,
Wow.
it's either we let the specialist know so that we find the right fit for them, and or also we're in the sessions asking the questions and helping the members understand so that we're all on the same page. Because most of the time people have a team, right? So if let's say we're in there with a subspecialist, we're there enough to also then share that information with the primary care doctor so that the member isn't trying to do phone tag or like telephone game of trying to convey different information and they don't have the background. So that kind of handoff is also very important because we want to be that advocate to walk the entire journey with them. To your point, there's a lot of factors that can come into play. The way that we approach
Mhm.
diagnostics is the same that we approach therapeutics, which is it's not a one size fits all and it's not a one kind of modality, right? It's always multimodal. So when you think about cancers, autoimmune, diabetes, heart disease, it's always the diet, the exercise, the avoidance of toxins. But the thing is that most of the
Mhm.
time when you're going in to see doctors, and this is not, a lot of
Mhm.
clinicians' fault in the sense that
Mhm.
unfortunately in the insurance kind of industry, you have like 5 minutes with people sometimes, and all you have enough time to get out is to say like, go don't eat bad things and go exercise. So for us, so we actually dive into the details of that. So what does that
Mhm.
exercise look like? Like for example, yesterday I just had a discussion with a member about doing,
Right.
the sumo squats, about the wall sits. Like we're literally talking about which exercises for which muscle groups. We're talking about if there's, neurodegeneration risk factors. Do you need a gait evaluation? Do you
Mhm.
need, and from there, how do we then help you with balance, right? Which
Mhm.
exercises? Diet wise,
Mhm.
if someone has issues with nutrients, if they have gut issues where they can't do supplements, which are the foods to avoid? What does it mean to have calcium oxalates and how do you avoid that but still get the anti-inflammatory vegetables? Like those are all nuances to the point of me saying, don't eat this versus like,
Mhm.
hey, we need to avoid this, but this is how you actually do it. And so to your point, there's a lot of AI out there. People can argue that you can just go get all the AI systems to tell you. But again, it's a lot of data out there and a
Right.
lot of people don't know
Right.
which ones to follow. And so there's nothing like having the
Right.
team that found it to then having the team that found it to tell you how to avoid it. And then not just that, but then follow up with objective testing later and say, did the things that we do here that we recommended, did it actually hit goal? And if not, is it not personalized enough for you to get to goal? In which case we continue to like iterate on that again,
Yeah, you know
right?
what? I think that's really such a great point because you're right. People, I was just talking to a colleague and he was just like, I can just go to AI and put something in and get, here's what you should do. To your point, when you step back and you get the entire picture, all of that data, um, you know, most of us would not be able to do that or do that. And, even the idea of trusting open AI to actually, I wouldn't trust open AI at this point, to that extent. But a quick question, which just sort of triggered for me which is, um, even you're accumulating all this data. Do you all, in looking at the picture, do you as part of your own process use some sort of machine learning or AI to actually help you organize that data? Because it's still, even though it's controlled and it's just a ton of data that you're looking at.
Yes. Well, so we definitely use a lot of AI technology for trending on the objective factors of like even let's say diagnostic imaging, right? So for example, a lot of radiologists will read things a certain way, but like we can actually use AI to measure the changes on the cellular fibrosis of the liver
Wow.
or like looking at the actual volume of the hippocampus in the brain and how does the AI measure that from year to year and the trend of that, or how do we measure the overall picture of all of these components and how is their mapping of like what's your risk factor this year compared to last year from of your metabolic disease or your lipids and things like that. So all of that kind of data configuration, so it's easier to digest, I think is still very important. But I think the thing is at this point, because of the complexity of how these things are being created, and also we're still human beings, like there's going to be anxiety and fear, like how do we present that in a data presentation format that is actually more empowering and not so scary, right? And so there's still a lot of this kind of taking a lot of this data and putting it in a way that's actionable. That's something that we can track over time, help to empower and encourage rather than discourage and cause anxiety. Like all of those things matter as to the outcome, because you can have very similar objective scientific data come out and one person could be overwhelmed and almost like I can't deal with this and shut down, versus someone else it could be presented to them in a way where they're like, okay, I have control over this. I've got a partner in this. Let's get this done. I can fix this.
And as someone like yourself who's devoted your entire career to, as you put it, to this movement, if you will, how do you see the larger field? Where do you see this going? Let's say if we were having this conversation, 3-5 years from now, what would that market, that industry, that movement, that I don't know if we could call it a specialty, but what would it look like?
So I think, there is definitely interest both on the professional end from clinicians as well as on the consumer end. And I think all too often, a lot of these trends and movements in medicine are to some degree demand driven. And so because there is a lot more education that general patients and consumers can see online and understand of it, they're going to drive this. And so we see very often clinicians feeling stuck in the sense that, well, we didn't get this kind of training in school. I'm being asked about it. I don't know what to do. And I think that's ultimately driving a lot of this partnership interest in working with Radence, is that they do recognize we're coming from this evidence-based perspective. And so to work with a company like ours where we're scientifically driven, they feel comfortable to then partner with us because their patients are asking for it anyways, and so in the future, I think there's going to be, to your point, it requires a movement. So my background's actually in public health. And so I know traditionally in medicine, to get a change in the way that we approach things, it takes a long time. Medicine's traditionally one of the harder fields to shift. And rightly so in a lot of ways, in the sense I get, we're dealing with human bodies, right? And so we want to always be very cautious, but there's a fine line between being cautious and then also just the bureaucracy of like insurance, red tape, et cetera. So like, I think this is why I went into private industry to try to drive this kind of movement forward, is because we will be able to be a bit more agile on our feet and drive it. And as we're creating the evidence, that's how we usually will see a shift, both academia, conventional and commercially, where everyone will shift in that direction, because there'll be enough data out there showing that evidence-based medicine in this specialty is required. And so people will not stand for it not to be done that way. And so, one thing that's very interesting is Radence has our founder, our CEO, a lot of the people in the company are very passionate about making sure that this is the way that medicine is being moved forward in the future. And so there's a strategy in play as to how we could potentially, hopefully help democratize this concept. But it really does take time, and it takes the early adopters, the people who are in our program and the people who are supporting our program, really helping us and seeing us to that vision point so that the data becomes strong enough so that we can really push it. And so, a lot of people also ask this concept, to your point, we were talking a little bit about the pricing, and a lot of, if you just even think about cars, right? Like a lot of the features that are now common day in all of the cars were initially created in higher end cars, because then the side sensors, the airbags, then we were able to demonstrate in the higher end cars that this is worthwhile. And then now it's in all the cars. And so our vision of this, program is to, a lot of this technology is still very expensive, but if we can demonstrate that power and that necessity, then later on the goal is to get this so that all of medicine is really focusing on it in that perspective.
Where are you located? Where is the
So
Radence? Yeah.
Yeah, Radence is actually so we meet our members where they're at. So we actually are able to take our protocols and drop it into all the major cities, but our physical location, our precision health hub is in West Palm Beach. But we have members in Boston, New York, Chicago, Texas, Florida, California. All of the major areas, we're actually able to take our protocols and drop it into our partners in those locations.
And you and I, we know that so much of this has to do with behavior change. So does Radence offer anything along those lines in terms of coaches or, yeah.
Yeah, so whether it's physical therapy, whether it's trainer, whether it's dietitians, whether it's therapy specialties that they are looking into, whether we give the guidance or we refer, it's all there in the sense that, again, if we can diagnose it, but we can't help you make a change, ultimately, there's nothing that really makes the needle move. So we want to make sure that whatever we're finding, that we're actually doing something to help the member be healthier.
So I'm looking at a sheet that you sent me in preparation for this, and there's a statement here that says, "Waiting for disease is no longer medicine." And I think I'm going to recommend to my podcast editor that that be the title of this podcast. Waiting for disease is no longer medicine.
Oh, I
Dr.
love
Julie
that.
Chen. Yeah, don't you like that? Yeah.
I
Well,
love that.
you made it up. So,
Yes.
but Julie, Dr. Chen, what a pleasure. It's so encouraging. It's inspiring. And I have to say, this is the type of medicine I'd like to practice. So thank you for what you do.
Well, thank you for what you do as well and getting this out to the viewers and the listeners. So great to be here. Thanks for having me.
My pleasure. Thank you.